Good Friday, everyone. I would like to talk about pharmacy law today. Um, a lot of patients and some pharmacists confused about pharmacy law every day, especially um, retail pharmacists uh, and people who work um, at the chain pharmacy like CVS, Walgreens, Walmart. Um, they face with the pharmacy law every day. So I would like to talk some important pharmacy laws that may be benefits for both patients and pharmacists folks. So I would like to talk about Schedule 2 to 4 controlled substance prescriptions. Schedule 2 uh, is different with Schedule 3 and Schedule 4 and Schedule 5 and the prescription only. So the Schedule 2, like oxycodone, um, you know, hydrocodone, morphine, uh, those medications, controlled substance, Schedule 2 or C2 prescription. So first I would like to discuss about day supply. Okay, so excuse me. So the day supply of C2 prescription, um, the maximum day supply for the C2 prescription is 30 days. But for some C2 medication, the maximum day supply can be 60 days, like for those medication or the dextroamphetamine or methylphenidate for the ADHD. So those medication um, can be 60 days supply. And some injectable infusion medication during the bumps, um, they might be okay for 90 days supply. So for these day supply limit is a different and vary state to state. So may need to check with your state law to see uh, what are they supply limits for the Schedule 2 prescription. And the Schedule 2 prescription cannot be refilled. It's prohibited. So no refilling for Schedule 2 prescription. For some reason, prescription for Schedule 2 might be partial filled because they don't have enough medication in stock, so they out of stock medication, and in that case, the pharmacist might give you some partial fill, but it's very complicated to do the partial fill. You know, pharmacists need to um, dispense the rest within 72 hours, and if after 72 hours the patient not come back for the remaining, then the pharmacist must report to the prescriber, the doctor who prescribes the medication. This little, it has some a complication if something happened after the buzzer fill. Um, and then it not permitted the patient request, so the patient cannot request a buzzer fill. Uh, the buzzer will only occur if the pharmacy uh, does not have enough medication in stock. So how long the Schedule 2 prescription is valid? Depend on state. Some state, uh, it set the time limit like 30 days limit. After 30 days, uh, the prescription is no longer valid. So um, you may need to get a new prescription for C2 medication if you cannot fill medication within 30 days. But for some medication, for some patients, like patients in long-term care facility, like a nursing home patient, or patient with a diagnosis of terminal illness, and the prescription may be valid up to 60 days from the day of issuance. So um, for the patient, the prescription um, can be filled within 60 days from the day the prescription was issued. So this is very important numbers and informations when you have the prescription for Schedule 2 controlled substances. You need to know some basic information to avoid, the prescription become invalid, and make sure you get enough medication. The total quantity total quantity prescribed instead of a partial fill. If you uh, don't get a partial fill within 72 hours, then you cannot get the rest of the medication. And remember to fill the medication within 30 days. No refills permitted. Um, and then understand the state laws to make sure, if you have the prescription for dextroamphetamine or methylphenidate for the ADHD, and some injectable infusion bombs, the medication for infusion, then you need to, make sure you fill the medication within the time limits. All right, if you have any questions, please let me know in the comment below. I'm going to talk a little bit about Schedule 3 and 4 prescription. So Schedule 3 and 4 prescription. There you go. Schedule 3 and 4 prescription. So again, the day supply, for state law, some state law is the maximum 30-day supply per single filling, or be spent at one time. Federal law say maximum 34 days supply per single filling. But only a 5 refill and 6 months. You only have 5 refills within 6 months from the day of issuance of the prescriptions. So after 6 months, you cannot fill the Schedule 3 and Schedule 4 prescription. Make sure you know the time limit. And only fill 30 days supply or 34-day supply per single filling. Okay, so as long as you have enough for medication for 6 months, if you have 34 days supply, then probably you don't have 5 refills, maybe 4 refills. So it might be we need to do some calculation of 6 months is equal 24. Probably you have 4 refills if 34 days supply. For box refill, yeah, if the pharmacist unable to supply the prescribed quantity due to out of stock or the patient request, so it's different with the Schedule 2 or C2 prescription. This C2 prescription, the patient cannot request a box refill. Okay, and then for state law, you might not exceed 30 days supply, and the total quantity in all box refillings may not exceed the total quantity prescribed. And then after 6 months from the day of the prescription issue, you cannot do a partial fill or any refill, nothing after 6 months. Again, the prescription may be valid for up to 6 months from the days the prescription issued. So these very basic but important information all patients and pharmacists should know to avoid any arguments when the time that the patient needs medication but cannot be filled, or too soon to refill, things like that. Generally, pharmacists may dispense the schedule prescription maybe only 2 days earlier. Uh, if the patient want to get the prescription too early, they only do 2 day 2 days early for most of the scheduled substances. All right, so this is some pharmacy laws that it occurs every day, and then you know some a lot of patients they don't understand this uh, why the pharmacist refuse to refill the medication too early, or why they cannot fill the prescription even though they have some refill remaining like that. And the pharmacist, I mean, the healthcare insurance might have some information. For example, if you fill the prescription multiple pharmacy, uh, the your insurance may let the pharmacist know that you already fill this medication from the other pharmacy. So the pharmacist will know if you already got the medication for the pharmacy. Right? If you have any question or concern about this pharmacy law, please let me know in the comment below. Thank you for listening. So I'm going to continue some very important pharmacy law. This is just for patient information. Good to know this information when you have a prescription, get it filled at the pharmacy. So the last time I talked about Schedule 2, Schedule 3, and Schedule 4 controlled substances prescriptions. Now Schedule 5 controlled substance prescriptions, or C5 prescriptions. Again, you need to understand the day supply on the prescription. So no federal or state law regulating the quantity of this prescription, C5 prescription, or Schedule 5 controlled substance prescription. So no law saying how many they supply, maybe anything filling any one time. For the refill, no specific or set time limitation. So for the C5 prescription, the law doesn't say how many days supply can be refilled. It's not like C free and C prescription. It limited 30-day supplies. So, but many states, may limit refills of C5 prescription by refills within a 6-month period. It's like C3 and C4. C3 and C4 it limits to 5 refills within 6-month period. So it depends on where you live. Your state may want set the limit, set the time limitation C5 prescription. The C5 prescription may be partial fill. So there is no law regulating partial fill for C5 prescription. But the total amount of all partial filling but not exceed the total amounts required. And when the prescription is expired, it's no specific or set time for expiration. So many states consider the C5 prescription is similar to C3 and C4 C3 and C4 prescriptions. Then the prescription may be just valid for up to 6 months from the day it was issued. So it still depends on your states. Okay. But if your state has no specific or set time for expiration, then the prescription may be valid for 1 year. But most of the insurance company and the pharmacy system is set up for 1 year cut off for prescription. In other words, the prescriptions become invalid after 1 year which were issued. This is very important information for you as the patient understand, why they give you certain day supply, and usually for those states who have no regulation on the C5 prescription, then they might fill up to 90-day supply. It's just like regular prescription medication due to 90-day supply. But if it consider C5 prescription as the C3 and C4, then it may only give you 30-day supply. And again, check your state regulation to see if you can refill the prescription beyond 6-month period. And most of the prescription is not valid after 1 year. Those very important limitation of the prescription. You let me know if you have any question for the Schedule 5 controlled substances, prescription, or C5 prescription. Thank you. So the last part of this type of pharmacy law is prescription only prescription. The RX only prescription, or some states they say C6 or Schedule 6 controlled substance prescription, either RX only prescription or Schedule 6 controlled substance prescription. So the day supply, so no law talking about the quantity may be dispensed at any single filling. So most of the insurance limit for 90-day supply. For people who travel overseas or something like that, might request 6 months supply, but like I say, most insurance companies limit for 90-day supply for prescription only medication. And then some medication, it's very dangerous to dispense over 3 months supply, like over 90-day supply, medication like antidepressant or antipsychotic. Those medication, they might limit to 90-day supply maximum, like medication like a Seroquel or Lexapro or some medication require to monitor your blood like Coumadin or warfarin. Those medications, they may not give you more than 90-day supply. That is the basic safety, not about insurance, not about the money. That is the safety. Most of pharmacists or the doctor, they don't feel comfortable, they are not comfortable to dispense more than 90. For the refill, there's no specific or set time limitation, but many insurance companies and pharmacy systems set for 1 year. After 1 year, you probably need to get a new prescription, or the pharmacy folks, they may call your doctor office to get a prescription renewed. Partial fill is permitted, however, the total amount or quantity in all partial fillings must not exceed total amounts prescribed per prescription. So when the prescriptions expire, I just say valid for up to 1 year from the days we issued from many insurance companies and pharmacy systems. No transfer of refill for the prescription only beyond 1 year from the day of issuance of the original prescription. So, uh, the pharmacy cannot transfer your refill to a different pharmacy if the prescription beyond 1 year. So after 1 year, most of the prescription is invalid of uh, insurance companies or pharmacy system. Um, you may ask a new pharmacy call your doctor to get a new prescription or get the prescription renewed. That's all you can do. That the old pharmacy cannot transfer your expired prescription, you know, to a new pharmacy. So this is very important information for you as a patient to understand how the pharmacy fill your prescription at local pharmacy. You know, when they get your prescription, they look at the day of the prescription were issued, and then the day supply, the prescriber or the doctor want, and then some prescription, yeah, they, like some chronic disease, you might request 90-day supply, like high blood pressure or diabetes, high cholesterol, those disease, those medical conditions, a chronic medical condition require you to take for a long time, then you might request 90-day supply for your convenience. Then most of the pharmacists accept that request from you. Um, you don't have to ask your doctor for that. And ask the pharmacy to fill a 90-day supply as your request. And then you should know the most of the prescription is invalid or expired after 1 year. Then probably you need to get a refill before that. Otherwise, you need to have the pharmacist call your doctor office to get the prescription renewed. Some medication require you to see your doctor before they can renew. Most of the medication, within your mental health condition, like depression or anxiety or the psych the psycho problems, and you need to see the psychiatrist before you get the prescription review. Or some medication require to monitor your blood, like coumadin, need to get the lab blood test draw before they can renew your prescription. And like that, you need to work with your doctor. The pharmacy cannot help you with those things. And within 1 year limit, the pharmacy can transfer your refill to a new pharmacy. For example, you got prescription with 11 refills, and then the prescription after 6 months of the day of insurance of the original prescription, then the pharmacist can call to a new pharmacy to get the prescription transferred. But after 1 year, they cannot do that. The prescription is no longer valid in their pharmacy system. I think most of the pharmacy set the 1 year cut off for the prescription only medication. All right, so that's all about the prescription. From C2, C3, C4, C5, and C6 prescription. And C6 prescription is the regular prescription or the RX only prescription. Each state they call different. And so you may have to check with your pharmacy, your local pharmacy, to see how they call the Schedule 6 controlled substance prescription. Sometimes they call the RX only prescription. Sometimes they call Schedule 6 prescription or regular prescription. If you have any further question or any concern, please let me know. I'm willing to explain pharmacy law. If you confused or if you don't understand anything about pharmacy, please let me know. I want to clarify or make sure give you the good information that can help you understand why the pharmacy give your medication, why sometimes they don't. They review your prescription. Thank you. Have a good one. Some of my keep asking different goal. I know. So when you go to Google and go INR, there's here is a basically go up INR or the range. Full range of INR is between 2 and 3 most indication, except for the mechanical mitral valve replacement or mechanical heart valve INR 0.5 to 2.5. That's correct, but also the other special INR is 2.5 to 2.5, and not only way by the mechanical heart valve. Sometimes if people who have deep vein thrombosis or DVT or the AFib that cannot be controlled by warfarin with the go-to-3. For example, people have been taking warfarin with the INR rank between 2 and 3, but still have stroke or still have recurrent DVT or PD. They may increase the INR range to 2.5 to 3.5. Make sure they're not having stroke or they are at therapeutic level. And sometimes they have the patient additional medication like aspirin, then the current DVT, OPE, stroke, and take over. And sometimes some people very high risk of bleeding. They may want to have those patients a lower INR range, maybe have to be below 1.8. Sorry, maybe 1.5 to 2.5. So for those people, they are very high risk of bleeding. Having the further question is, how in vegetables. So you should eat some greens, but you need to be consistent with your vegetables. You should eat same amount of vitamin K or same amount of greens every day to make sure your warfarin stable in your body. You have to eat consistent. You need to know how to measure your vitamin K. For example, spinach or kale contain a lot of vitamin K. So if you eat, I would recommend that you should eat low to moderate amount of vitamin K. So if you eat half of a raw spinach for one day, the next day you should eat like 2 or 3 cups of raw cucumbers or tomatoes, like that. But dark leafy vegetables or dark leafy greens contain more vitamin K, like kale, spinach. Light vegetables contain less vitamin K, like cucumber or tomatoes contain less less vitamin K. So I would recommend that you should eat low to moderate amount of vitamin K, but you must be consistent every day to make sure that your warfarin stable stabilize your body. Generally, when you see this question, can you eat food with vitamin K on warfarin? Yes, I would say yes. You can eat some food with vitamin K, but you must be consistent and you should know how to measure the amount of vitamin K in each food in order to make sure you eat a similar amount every day. What foods should be avoided when taking warfarin? Well, I don't think that you need to avoid any foods when you're on warfarin, especially the food affect your warfarin like greens or vegetable. But some foods, may affect your bleeding, like garlic or some um, other herbals, it may increase your iron, so it may increase your bleeding. So I uh, try to avoid those medication may cause bleeding. The vitamin K does not increase your iron level or does not raise your iron level. It decreases or it lower your iron level. So what it means when it's low iron level? So when your iron low, you are at increased risk of blood clot. When your iron level is high or critical, is increased risk of bleeding. That is why you have to make sure you are in a stable and in the range. Um, there are two typical range. One, the normal range for certain medical condition like EVT, AFib, the normal range between 2 and 3 for the INR. For mechanical heart failure, the INR level is between 2.5 to 3.5. So it depends on medical condition. You have a different INR range. You have any further question on this topic or the issue? Please let me know in the comment below. Thank you. Hello, Yatu. This is a good question. What is difference between both Tylenol? Uh, I say Motrin is a non-inflammatory steroid drug. So it's used for mostly for inflammation pain, like ache or muscle pain, muscle cramps, like that. Whereas the Tylenol is used for non-inflammatory pain, like my headache or my fever or my back pain. But just pay attention on the side effect for each of these medications so you profit. So, Motrin may affect your stomach like ulceration when you use very high dose or you take it in empty stomach. So, and then it may affect your kidney also. So, when you take Motrin, you have to take with a full stomach, and you can take 15 or 30 minutes after eating. Um, and Tylenol may affect your liver. So you should not exceed 4,000 milligrams of Tylenol for any circumstance. So generally you take 500 to 1,000 every 4 to 6 hours, but do not exceed 4,000 milligram a day may affect your liver. Especially if you have any liver disease, you should consider heavily um, when you take in Tylenol. Um, and when you know, drinking too much alcohol, you should avoid taking Tylenol. May affect your liver. So those this is very important to consider when you should take Tylenol or Motrin. That's pretty much what is different between Tylenol and Motrin. If you have any further question, please comment below. Let me. Thank you. Hello. This is a very good question. Uh, Lots of people taking fish oil nowadays for their cholesterol um, and other medical conditions such as arthritis, inflammation, or uh, or the heart. So the there are some drug interaction between fish oil and water. Um, some people may experience more bleeding or bruising when taking fish oil and water. So if you have any abnormal bleeding or bruising, um, you should report to your doctor. Anyway, before starting fish oil or any over-the-counters or herbals, you should check um, the doctor who managed your warfarin to make sure he or she aware of new medication or over-the-counters that may increase risk of bleeding when we are on certain medication such as warfarin. And I think fish oil may not affect other oral medications such as Alaquix or Eroto. Hi, Frank. Pam, it's a good question. Basically, this is a general question I used to have. Um, Typically, is no, we should not take Motrin while we are on warfarin because Motrin um, is a non-formulary steroid medication. It may cause bleeding when taken with anticoagulant. such as warfarin or Eliquis, Yeroto, any type of anticoagulant. Uh, we should not take Motrin. So if you are not allergic, not allergic to Tylenol, you should take Tylenol instead of Motrin. Hello, young people. This is a very good question. A lot of people ask me this question when I manage the comedy clinic. Yes, some people have to take both warfarin and aspirin. But not a lot of people. Some people have to take both warfarin and aspirin. Aspirin generally take for the platelet or certain people, certain patients have the AFib, but they don't have additional factors. So they only need take aspirin. But when they have additional factors like over over 75 or have diabetes. So generally the JAK2 score over 2, they should take the anticoagulant instead of take only aspirin. But some people have to take aspirin and warfarin because they have additional conditions. For example, people who take warfarin for the AFib, and they have to take maybe aspirin for the stent. People who have the stent in their body, they may have to take aspirin for 1 year also. Some people have to take the other anti-platelet like Plavix. So depending on your medical history, your doctor or your pharmacist will review whether or not you should take both aspirin or warfarin. Thank you for your question. Do you have any other further question? Please let me know. Thank you. I young thing, uh, this is another good question. I think uh, generally for the major procedure or surgery, I would recommend to hold aspirin for 7 days, but you need to check with the heart doctor to make sure they are okay for how to switch from warfarin to Eliquix. So you can go to Google and type in switching from warfarin to Eliquix or Abixi-ban. You can find uh, about 400,000 results. Okay, but the first few um, website help you to understanding how to switch from warfarin to Eliquix or other direct acting oral anticoagulants. So for Eliquix, we'll switch to the Eliquix when the iron are less than 2. So, excuse me. So, for example, if the patient is therapeutic at the Coumadin clinic visit, I used to have the patient stop taking warfarin about 2 days prior to starting the Eliquix. So, at that time, I had time to send out the medication to the patient. For example, if I overnight, then the patient should receive the medication the following day. Or if the patient pick up the medication at the window at the pharmacy, then the patient have the medication ready to switch to the Eliquid from warfarin. So again, it depends on the iodine level, so we can um, eh, have the patient switch from warfarin to Eliquid from the outpatient setting. So if the patient inpatient or hospitalized, then it easy to stop the warfarin and try to retest the iron to make sure it less than 2 before start taking the Eliquix. It's more easier for the patient to switch to the Eliquix when they're still at the hospital. But if the outpatient management, then you need to like stop the warfarin for 2 days. If the iron at the therapeutic level, and then start the Eliquix to make sure the iron less than 2. If the iron a little bit high, like 3.2 or 3.3, then I would would recommend to stop the warfarin for 3 days prior to uh, uh, starting Eliquix. But what happened if the iron at the uh, you know, really high, like 3.6 or above in the time visit, then I would recommend I would reduce the dose or take a partial dose and then retest iron in 1 week to make sure iron level therapeutic before switching to the elements. And when the iron at the therapeutic level, and just try to hold 1 or 2 days prior to the Eliquix, prior to starting the Eliquix to make sure the iron is. The COVID-19 caused VTE, the thromboembolism, venous thromboembolism, the DVT or PE, deep vein thrombosis or pulmonary embolism. You can go to Google, you can type COVID-19 cause VTE. It will show up, about 840,000 results. So the first few results indicate that the patient with the COVID-19 infection might experience an increased risk of venous thrombosis, the DVT or PE. So, and then you can see the most popular website in the medical field is uptodate.com. It also shows that the COVID-19 patient might experience the coagulation disorder. And then in the following website, Boston Medical Journal.com is also show that the patient with the COVID-19 are associated with the venous thrombosis. So, yes, the answer is yes, the COVID-19 might cause the venous thrombosis. So, I have experienced some patients who have the COVID-19 vaccine and they experience the increase of the iron. So the COVID-19 vaccines might increase the iron number. It's not much. It's about between 0.5 to 1. For example, people who normally have iron around 2.5, they may increase the iron to 3.0 to 3.5 after vaccination. So, but it not last long. Usually they experience the iron increase in about 3 to 4 weeks. And after that, they back to the normal target, normal range. So in those 3 to 4 weeks, the patient who have increased the iron due to the COVID-19 vaccines are used to decrease the warfarin dose a little bit, like maybe just a half dose per week to make sure that I'm not outrange, it's not super therapeutic. So, excuse me. So yes, some people have a concern whether or not the COVID-19 vaccine affect the iron level or not. Yes, they, they do affect the iron level, but not much. Thank you. So how you switch from Eliquis to warfarin? You can go to Google and type in switching from Eliquis to warfarin. You buy about 300, more than 300,000 results from this search. But the top few website have some very important information for you. The first one say converting the Eliquis or this event. They recommend start warfarin and stop this event 3 days later. So this is correct, but this depends on the warfarin level. For example, the baseline for warfarin, before you start warfarin, you need to get the baseline warfarin. Okay? And the normal warfarin is usually below 0.9 or 0.9. So around that level is normal warfarin. The people never on warfarin before. But how about if the warfarin level at that time at the baseline very high, like 0.2, I mean 1.2 or 1.3, like that, and you may need to stop at this event maybe days or so. And then the second option, they say maybe stop at this event and then start the parenteral anticoagulant or the injection anticoagulant. So, like Lovenox, and then warfarin at the same time. So, for some people, they are very high risk of stroke or high risk of complicated situation. So you need to make sure that the patient not have any kind of life-threatening issue. So At that case, you might, when if you want to switch to uh, warfarin, then you probably need to make sure warfarin at a therapeutic level. In order to do that, because it takes about 3 to 5 days in order to make sure that I get to into the therapeutic level. In order to make sure that they need to have some form of injection, like local injection, to make sure the patient is not risk of having stroke or dangerous blood clot. So that's about what you need to know when you uh, switching from aliquid to warfarin. But you need to make sure you have the baseline iron, and then based on the iron level, you may need to uh, to make sure when it's safe to stop the aliquid. Maybe 3 days later, if you have no more baseline iron, if you have high baseline iron, then you might need to consider to stop the aliquid a little bit sooner. And then if you think that the patient is very high risk of having stroke or dangerous blood clot, then you need to make sure that you have some form of the injection, like low venom injection, make sure um, the iron level at therapeutic before you stop the low injection. Make sure the patient not having stroke or dangerous blood clot, like blood clot in their lungs. Thank you. All right. So, how do we switch from warfarin to Xarelto or rivaroxaban? This one is a little bit different. Uh, you can go to Google and type switching from warfarin to Xarelto or rivaroxaban. You have about more than 400,000 results. Okay? And for the first few ones, there is some information that tell you how to switch to Xarelto from warfarin. So right here they say from warfarin, stop warfarin and start Xarelto when I less than 3. You know that for the aliquots or Bedex, when are less than 2, but for Xarelto it's than 3. Why? Why is different? Because Xarelto is kind of little bit, it has a little bit longer half-life. So when it has longer half-life, means the medication lasts longer, and then it take longer time to get to the peak effect. So when the iron is less than 3, so you you stop the warfarin and start Xarelto. It takes some time for Xarelto to work in your body. So that's why they want the iron less than 3 instead of less than. So and then similar to Eliquis, if the patient had the life-threatening blood clot or having high risk of stroke, then you may need to consider the anticoagulant injection, like luminol injection. So, I mean, when you want to switch from Yeroto to warfarin, and then you might need to consider the luminol injection to make sure the patient don't have any stroke risk or any uh, life-threatening blood clot. But when you switch from warfarin to uh, Yeroto, then you only need to know when the iron is less than 3. Then, but it's different from the hospital libation and the outpatient patient. So for in the hospital, you may monitor iron or recheck iron maybe daily basis to make sure iron less than 3 before you start the Yeroto. But how about the outpatient setting? You don't do the iron daily basis. How do you plan for that? For me, when the iron, for example, at the therapeutic iron, then yeah, I just tell the patient to stop the warfarin, and I overnight the Yeroto, or I send the patient to the pharmacy window so they can pick up the Yeroto and start the Yeroto next day, the same schedule they are taking warfarin. So when I know the iron therapeutic, it's between 2 and 3, then I'll say go ahead and stop the warfarin for tonight and start the Yeroto tomorrow. And I know the patient will receive the medication at window, or you have the patient tomorrow via the overnight service. And how about if the iron are too low? If it's too low, then I would just say take half the warfarin at their schedule, and then start the Yeroto the next day at the same schedule of warfarin. What happens if the iron are too high? Like 3.5 or 3.5 or 4, or about 3. So if it is if the INA above 3.2, then I would just say stop the warfarin for 1 day, and then go ahead and take Yeroto the next day. But if it's 3.5, then I might recommend to stop warfarin for 2 days prior to take Yeroto. If it's 3.6 or above, like 4, and then stop the Yeroto for 2 to 3 days. But if it's more than 4, then I will have to hold the dose and have the patient to come back, in 1 week and to retest the iron and go from there. But I don't. If it's above 4, and I have to have the patient to reject the iron. That's how I switch from warfarin to Yeroto. How to switch from Yeroto to warfarin. You can go to Google again and type in switching from Yeroto to warfarin. You have about 45,000 or 4,500,000 results. So that's a lot, but for the first few um, results, you can learn how to speak to warfarin from Yeroto. So they recommend that um, you need to continue Yeroto warfarin. You start warfarin and continue the Yeroto together overlap for 3 days. So you stop the Yeroto in 3 days. Switching from Yeroto to warfarin. Okay. So you start warfarin and then Yeroto, and then stop the Yeroto in 3 days. Okay. So hopefully in 3 days warfarin start working. Okay. But if the in 3 days, if you test the I9 level is still too low, like 1.2, 1.3, 1.4, and I would continue Yeroto for 1 or 2 more days and increase the warfarin a little bit to make sure the patient is safe from blood clot. Make sure that to tell the patient to remember to stop Yeroto as instructed. Some patient they forgot to stop the Yeroto. So that's the main thing. By the patient, you might call the patient. Make sure they stop the Yeroto as instructed. Otherwise, may cause bleeding. So usually for the new warfarin start, you check the iron level maybe twice a week. Monday and then the next iron Thursday or Friday. So I would recommend that you should, start warfarin and then stop the Yeroto in 3 days. And then recheck the INR. If the INR is still too low, then I would recommend continue for another 1 or 2 days. Then adjust the warfarin dose to make sure it's not too high and not too low. And then recheck in about 3 days to make sure the patient is not at risk of blood clot or stroke. And then to make sure the patient is not continue taking both medication, the Yeroto and warfarin. Okay. So if the INR is still very low and probably need to increase the warfarin to make sure it get to the therapeutic level. And have the patient to report any abnormal bruising or increased bleeding risk. Thank you. How to switch from warfarin to Badax? Go to Google and type in switching from warfarin to Badax. you have about 340,000 results. The first few top results, you may have some information. Here, pharmacist.com give you a very quick information. So you stop warfarin and start Adaxa when INR less than 2. So this is general recommendation, but how you apply if you are from the hospital setting. If you work in the hospital, you might check INR daily. So when is INR less than 2, then you start Adaxa on the same schedule, start the warfarin. And Adaxa is twice a day doses. You take one capsule twice a day. How about the outpatient setting? If you check the INR and INR is less than 2, and the patient has the outpatient clinic, and you are able to give the patient the medication, the Adaxa, then the patient can start Adaxa at the schedule of warfarin. Stop warfarin and start Adaxa. But when I'm at the therapeutic level, like between 2 and 3, so you have to wait, like hold for 1 day to make sure I'm less than 2, 1 to 2 days to make sure I'm less than for the patient start the Adaxa. But if the patient need to, if you need to send the medication to the patient home, you overnight, it may take one day. And then if the INA is at the therapeutic level, then I need to go 1 or 2 days, make sure INA less than for the patient. If the INA at the time of visit is like 3 point above the level, 3.1 to 3.5, then probably the patient needs to hold more than 2 days, like maybe 3 days. And how about if the INA, above 3.6 or so, then probably the patient needs to come back to reject INA, just hold one or a half dose or 1 dose to make sure that INA back to the normal range, and then reject it before further notice for further instruction. Depend on the INA level and inpatient or outpatient status to provide best recommendation when doing from warfarin to Adaxa. How to switch from Adaxa to warfarin, or from a bigger trend to warfarin. So go to Google and I've been switching from Adaxa to warfarin. You have about 400,000 doses. Again, when you look at the first few uh, top websites right here, stop warfarin and start the bigger trend when less than lower limit of therapeutic range less than 2. Uh, Pharmacist.com recommend stop warfarin and start the bigger trend when So, um, in the hospital setting, you can do daily iron. So you check the iron, it's less than 2, then to stop, open, and start the bigger trend. But how about the outpatient setting? Uh, at the time of visit, when iron less than 2, then probably you can hold the bigger trend 1 day and then start the Badaxa. If the patient has the medication um, on hand, then you may, when the INR less than 2, stop open and start the Badaxa. If the patient um, doesn't have the Badaxa on hand, like you need to overnight the medication, and like that, it may take 1 day or so to get to the patient home. So you need to, if the iron at the therapeutic level, then you just hold the bigger trend for 1 day or 2 days prior to start the Adaxa. If the iron like 3.2, 3.1 to 3.5, then I would hold open for like 3 days or so to make sure that I'm not less than 2, then start the Alexa. But if it's greater than 3.6, I would hold the open for 1 day and have the patient come back in 1 week to recheck the INR for further instruction. So it depends on the INR level in order to recommend when how many days need to hold open in order to get the INR lesson or switching adapts. I'm talking about the Alaquix versus warfarin. So why you need some people take Alaquix or Abixaban versus warfarin? So when you go to Google and you just search for it, Alaquix versus warfarin, you will have about 600,000 results. Okay, so for the first few one, you can find some quick information why they choose Alaquix versus warfarin or vice versa. So the first one from myheart.net, they say Alaquix is shorter acting than warfarin. Excuse me. So Alaquix is shorter acting than warfarin, and the blood thinner effect is quicker gain or loss after about 24 hours. Aliquid rarely require breaching because it is shorter acting and can be safely stopped a day or two before any medical procedure or surgery. Yeah, so it's Aliquid's image and the warfarin image here. It's not always the case. It is just general information. I've been working for the Anticoagulants clinic for many years. So yes, Aliquid, you have to take one twice a day. Whereas the warfarin or coumadin, you take one tablet, one dose a day. So it have a longer half-life and it take a longer time to get to the peak effect and get into stable state. So usually warfarin take 3 to 5 days to start working in your body when you just start warfarin. And then it take 1 to 2 weeks to get to the beach. Like the peak. And then it become a stable state after 2 weeks or so. Aliquid is just similar to the low enough injection or enough separate injection. So Aliquid is the fixed dose medication. Either take 5 milligrams twice a day or 2.5 milligrams twice a day for certain patients. So it works every 12 hours medication. You should take same time every day, every 12 hours, and then the warfarin the same time every 24 hours. Aliquid is very expensive medication compared to warfarin. Aliquid, even though you have a copay, it is very expensive, like $500 per month, and then about 1,000 or more for 90-day supply. Either warfarin is like $10 for 3 months or so, so it's very cheap. Aliquid is a new medication. I think it's available in 2018 or so, 2017 until now. It's been studied and it's shown that the Aliquid is effective just like warfarin. And for elderly people, it may be convenient. They don't, have to go with the confused dosing with warfarin. Aliquid just take one tablet, fixed dose twice a day. So it may be best for a lot of patients, especially elderly people. Warfarin is very complicated in dosing. Some day you need to take one tablet, some day you need to take half tablet. It's a weekly dose, but you have to take every day. It's so very complicated. Another advantage of Aliquid is diet. Warfarin might be affected by the vitamin K foods like greens, vegetables like kale, cucumbers, spinach, broccoli, things like that might affect warfarin. Some if you eat more vitamin K food, it may make the iron level go down. And if you eat less vegetable, it makes the iron level go up. So yeah, must be stable with vitamin K foods every day. Aliquid is not affected by vitamin K foods, so most of people happy with that. They don't have to watch for their diet. And another advantage of aliquid compared to warfarin, aliquid doesn't require close monitoring. Okay, some people, if you are over 75 and you have normal kidney function, normal liver function, you only required to test your blood, every 6 months. And then for warfarin, you have the maximum they can extend the follow-up is 6 weeks. Okay, so 6 weeks you need to come back to get the iron test, your blood test, to make sure your warfarin level is not too high or not too low. When the iron too low, it means you don't have enough warfarin in your body. When iron too high, it means you have too much warfarin in your body. It may cause bleeding. So that's why they have to test your iron level frequently. If you are stable, your iron are very stable, then you can come back in 6 weeks. But if your iron level is not stable, you have to come back frequently, like weekly or 2 weeks or 3 weeks, depending on your iron level. If your iron level at critical, it means it's too high, like 5.0 or 6. Then you might need to hold warfarin and come back in 3 days or 2 days, things like that. But aliquid is not frequent follow-up or test. No test required to make sure the aliquid is enough in the body. No, we don't have that test. That test is very expensive and is no required. For the side effect, somehow, and then for elderly patient, aliquid may be better than warfarin because they don't confuse. They are not confused with the dosage. So if they take the aliquid with the instructed dose, then they have no problem with the bleeding. But for warfarin, sometimes they confuse with the dose, and then they may take a wrong dose, and it will cause bleeding. That's one of the reasons. The second, based on the study, aliquid may be better in terms of solvent bleeding, where to warfarin for the elderly patient. And then the aliquid is, like I say, it's just like low enough injection, so you don't have to be breached before the surgery, because you may only need to hold for 2 days prior to the major surgery or procedure. But depend on the kidney function. If you have a bad kidney function, then you need to hold more than 2 days, like 3 or 4 days, depend on your kidney function. And the Eliquis, they only need to monitor the side effect, which is they need to bleeding. So they need to test your complete blood count to make sure the hemoglobin is not too low. If the hemoglobin too low, it means you might have some kind of internal bleeding. Then you need to pay attention on Eliquis, and then you need to go to see a doctor, the stomach doctor, to make sure it's not caused by the Eliquis. And then you need to check your right when you're on blood thinner medication. You need to check your stool and your urine frequently to make sure any kind of bleeding. Check your skin to see if any abnormal bruising. Those things that you need to pay attention, and you need to avoid any physical activity that easily cause fall. So those things need to be counseled when you're on any kind of blood thinner medication. So Eliquis generally is maybe better than warfarin in terms of side effect, and then it's more convenient than warfarin because the dose is a fixed dose, and they're not required to test frequently, and they're not the diet, vegetables, greens do not affect Eliquis. So more convenient, and it might be better in terms of side effect for some people. The disadvantage is it's so expensive. Some insurance, some healthcare insurer, they don't pay for it. So you need to work out with your health insurance to make sure they cover. And if somebody worry about their therapeutic or their how the Eliquis work in their body, how do they want to know if enough Eliquis in the body or not. So if for some people like that, they may stick with warfarin. They don't want to try the medication. You know, if not, it does not need the blood test to make sure it's not too low or too high like warfarin. And some people need to take Eliquis with a lower dose, like 2.5 milligrams twice a day. No people because they over 80 years old, and their weight is under 132 pounds, things like that. If they have those two factors, then they require to take a lower dose. If their kidney function, if their creatinine lesser than greater than 2.5, then probably they need to take a lower dose. For certain people, like people on dialysis, they may be not the best candidate for the Eliquis. They should stick with warfarin. So, if you have any further question or concern about if you are taking any blood thinner medication, please let me know in the comment below. Today I'm going to talking about uh, the Alaquix or Abisiban versus Geroto or Rivaroxaban. So, how do we know which one is better? How we do we know um, how to choose one of these medication for our patients? So first, these medication have similar indications. FDA approved for stroke prevention in non-valvular AFib or atrial fibrillation, and the venous thromboembolism treatment for prevention for deep vein thrombosis or DVT or pulmonary embolism PE. So first we need to look at the renal function to choose this medication. Generally, Aliquis is better for people who have renal impairment or renal dysfunction. Um, Most of the elderly people who over 80 years old do have renal problems, you know. So we should start or initiate Aliquix instead of Yeroto for patients over 80 years old. Aliquix, we need to use precaution when serum creatine clearance less than 25 or serum creatinine over 2.5. For these patients with significant renal dysfunction, we need to caution. We need to monitor closely, especially we need to test kidney function, the renal function, to make sure patient has no bleeding. For people who have the creatine clearance less than 25 or serum creatinine over 2.5, you might need to reduce the dose to 2.5 milligram twice a day instead of 5 milligram twice. For Yeroto, we should avoid patients creatinine clearance less than 30. So I just mentioned you should not start Yeroto for patients over 80 years old who have some kidney function problem. This medication generally absolutely contraindicated in patients who have mechanical heart valves, active liver disease like active active hepatitis, severe cirrhosis, or significant LFT elevation. If the AST or the the AXT or the ALT over 2 to 3 times their upper limit, then we should not use this medication. People who are pregnant should not use this medication. For the side effect, the most concern and common side effect is bleeding. So the Eliquis is better than Yeroto for the stomach or GI bleed. So people who have concern about stomach bleeding or they have some kind of stomach problems uh, history, then we should start with the Eliquis versus the Yeroto. Dosing, the Yeroto may be advantage compared to Eliquis because Eliquis is taken every 12 hours or twice a day, but Yeroto take once a day or every 24 hours. But it's must take with a full meal, full stomach. So there is one advantage of the Yeroto compared to the Eliquis because it's take once a day instead of twice a day. For people who have problem to remember taking the medication, then they may start with Yeroto if they don't have any other issue like bleeding risk or kidney problems. For some patients, they need to use the feeding tube, and probably the Eliquis is recommended. These medications, they have similar drug interaction. They should uh, avoid the some inhibitors medication, like um, CYB 384 and PGP substrates. So CYB 384 inhibitor and PGB substrate. They have similar antidote or reversal agent. The andexanet alpha or andexa, the brand name. So generally, the Eliquis is recommended more than the Yeroto. Only a few or some patients want one daily dose, then they want to start with the Yeroto. You let me know if you have any question on these two medications. Thank you. All right, the next topic I want to talk is Eliquis versus Pradaxa or dabigatran. So I have a similar indication. FDA approved for stroke prevention in non-valvular AFib, venous thromboembolism treatment for prevention. Precaution. So the Eliquis should be used in precaution when the creatine clearance less than 25 or the serum creatinine over 2.5. Typically, we use the Aliquix with a lower dose when people have um, this level, creating clearing less than 25 or serum creating greater than 2.5. For Badaxa, we should avoid when creating clearing less than 30, and it's not recommended to start in patient with creating clearing less than 50. So creating clearance at 60 or above is considered a normal renal function. When it's less than 60, it's not normal. And then when it when creating clearance below 50, then we should not start Pradaxa. And this medication contraindicated with patients who have mechanical heart valves, liver disease, active hepatitis, cirrhosis, significant LFT elevation. When people have the AST or LFT greater than 2 to 3 times of their upper limits, then we should not start the Aliquis or Badaxa. Pregnancy, people who are pregnant, they should be avoided taking this medication, Aliquis, Badaxa. The side effect, Aliquis is better in terms of stomach bleed or GI bleed. Badaxa might increase the GI side effects. So people who have stomach problem like peptic ulcer or the colitis or something like that, they should avoid taking Badaxa. Dosing, the Aliquid and Badaxa have similar dosing. They take they should be taken every 12 hours or twice a day. For the feeding tube, Badaxa is not recommended. The Badaxa dosage form available in capsules. So the capsules cannot be crushed or opened. Capsules may be stored. It must be capsules of the Badaxa, but be stored in original containers for about when it's open, it's only good for 3 months to maintain their efficacy. When it's open and then it's over 3 months, the medication no longer have the efficacy that it should. So if we open the container, then we should not use this medication if it's over 3 months. With that issue, we don't recommend people to use the bubble bag. For some hospital patients, they used to have the bubble bag for like 90 days set up, and then this medication must store in the original container to protect from the light, and they should not be used in the bubble bag setup. The Badaxa do not have interaction with the CYB3A4 drugs. It has a little bit different with the drug interaction. The Aliquix had the antidote or reversal agent. It's called the Andexanes alpha or Andexa. The Badaxa antidote is idacruzumab or Brexbite. So they have different antidotes or reversal agents. So generally, Badaxa is less common than Aliquix. Badaxa generally used for those people who have the good renal function and they are young. Otherwise, Aliquix should be started in patients have the increased risk of bleeding, have stomach problems like peptic ulcers or GI bleeding, and have renal function problems. And the big disadvantage of the Badaxa compared to Aliquix is the Badaxa cannot be used in the bubble bag setup for the hospital patient. Yeah, the patient who need to use the bubble bags for their medication for all of their medication. All right, if you have any further question or concern, why we choose the Aliquix versus Badaxa, or why we choose Badaxa versus Aliquix, please let me know in the comment below. Thank you.